Hello, Elizabeth Hinkson with Acute Care Education. For Clinical Academy, both Med-Surg and Progressive Care, we are going to look at suicide prevention. So suicide prevention and safe management of suicidal patients is highly regulated, and so we're going to need to make sure that we're careful with the process. So we're going to kind of walk through both assessment and management. Now, as an acute care educator, I am definitely not a mental health expert, so you'll notice that this presentation was built primarily by our mental health CNS, Gail Springer. So what we hope to do in this presentation is, again, talk about how to safely manage, how to best determine somebody's suicide risk level, and then talk about how we keep them safe while they are here with us in acute care. So we want to consider what brought us here to talk about suicide today. So a couple of things. The first one is that Washington State Department of Health, before COVID-19 took over everything, in the last couple of years, did a bunch of work on looking at suicide as a public health emergency. And so they learned a couple of things. One of which is that there really aren't a lot of predictors, right? You can't really look at someone and be able to be like, oh, definitely a risk, right? But what they did find was that most people who did attempt suicide had come in contact with a healthcare provider sometime in the last year. And so healthcare provider as in their provider at their clinic or somebody like us in acute care or through the ER. So because of that came down the mandate that all alert patients would need to be screened for suicide risk because, again, no real predictors, right? So that was the DOH. About the same time, the Joint Commission started looking at suicide also and made it National Patient Safety Goal number like 15 or something like that, right? So they are also looking at it. And on top of that, Providence as a system redid how we screen and categorize people with suicide risk. So all three of those things together has kind of landed us here today for talking about suicide risk. So one of the things that kind of came out of this, especially with being highly regulated, is what is the duty of the nurse? So we have to remember that in acute care, where we see people for kind of really a short period of time, the average stay is still under 4 days. So in that time, you are not going to fix someone. Your job instead is to keep somebody safe. We will keep them safe, and mental health issues are a long-term issue that's really meant to be managed in the community. So we will, keep them safe and plan for a safe discharge, whatever that looks like for them. So if you're going to keep somebody safe, though, then you are responsible for knowing what is it that you're keeping somebody safe from. Another way of saying that is, well, okay, what is the most common way that somebody would try and kill themselves in hospital? Well, we keep them away from guns and knives and things. We do a good job of locking up all of the pills. So what is left to you? And the answer to that is hanging, right? So to hang yourself, you have to have what is called a ligature point. A ligature point is what is it that you're going to tie your noose to? Turns out people are crafty when they are looking for things like that. The ceiling tiles, it's all, most of our units have the false ceiling. So you push the tile up and away, there's a bunch of pipes and wires there. Almost all of our doorknobs, you can take your bed sheets, tie it on one side, flip it over the door, and there you go. Gail has a story about somebody who went into the bathroom, shut the door, and they used their patient gown, and they tied it to the toilet paper roller thingy. They laid down on the ground and rolled around a bunch to try and asphyxiate themselves, right? So there is a couple of, or a lot of things that we wouldn't normally think about. So when we look at maintaining a safe environment, we will need to consider ligature risk. And as an acute care nurse, we aren't really used to looking at that. So we're going to look at some resources that will help us do that. So we will need to screen and categorize and then ensure a safe environment. And again, a safe discharge. So suicide and suicide prevention can be difficult subjects for our patients and our families. Remember that part of our duty as a healthcare provider, as a nurse, is to have those conversations that might have been hard for a family to have. So we do carry responsibility for setting up a caring environment so that you can ask the questions that we're just about to go through and give your person as much opportunity as you can to be honest with you. The things that we're talking about are very sensitive, they're personal. And once a person divulges something to you, they have lost control over those thoughts and feelings. Like you now, are, free to know and act, right? So there's a big trust issue. And so the responsibility is upon us as the nurse to do our best. Not everybody's going to be in a position where they're ready to talk about it, but we want to try and create an environment where they could. So that's where we come up with create a sensitive and supportive caring environment. And the other thing about that, you may have noticed in Epic, so you're doing your giant admission screen, and you're going through the questions, and you get to the kind of that part where you're out in the minutia of somebody's life, and you're like, do you live in a house or an apartment, and how many stairs? And you know what comes right after that? Suddenly you're a very, very personal, and you're like, so, do you wish you went to sleep and never woke up, right? It's a very abrupt switch. So you need to be able to cue your person that there's going to be a change in topic. What we have historically done is we've realized how awkward of a transition that is, and so we just have avoided these questions entirely. We've made a snap judgment about somebody and been like, this doesn't apply to them anyway, and it just makes everything weird, so I'm not going to ask them. We don't actually have that. We're not in that position. We can't make that judgment, so we will need to figure out how is it that you are going to cue your person. Now that idea about what should we say so that we can broach this subject in as comfortable a way as possible, that question went to the Patient and Family Advisory Council. Now what they suggested we say, something like, we ask these questions of all people because we know it is an issue for some and we don't want to miss anything. So you are welcome to say that. If you're listening to that and you're like, wow, I would never say that, that's okay. What is your transition? How are you going to build that environment so your person has the best chance of being honest with you? A couple of other things about screening for suicide. We all get to the screening tool, the Columbia Suicide Severity Rating Scale, through slightly different avenues, depending on whether we are in the ER, we're in acute care, or peds. So we all have kind of a different initial screen. Now the only one that we're actually interested in right now is the one that applies to acute care, right? We would be looking at the PHQ-4, sometimes referred to as pre-screening. Now when you're going down, again, your assessment screen, on the left it will say suicide, and the questions that you see are actually the PHQ-4 questions. Means personal health questionnaire, and there's 4 questions. This is actually 2 subsets. There is the anxiety questions and the depression questions, and depending on how you score means that you will either move on to the official suicide screen, that's the Columbia, or if you will not need to and will advance to the rest of your admission assessment. You'll notice in the screen that you're looking at that it tells you how this is going to be scored, like what value do you have to get in order to open up the actual suicide screen. And so it's a 3 or greater in either anxiety or depression. And then Epic will actually automatically open up your Columbia Suicide Severity Rating Scale. We're going to click through some of these slides because they actually apply to the ER and to PEDS, and we're just going to focus on our acute care slides. So when we open up the Columbia Suicide Severity Rating Scale, or Epic opens it for us, that's going to be kind of the last time that Epic actually helps you with what you should do next. It's not going to tell you how to score someone after the questions or it's not going to open up your care plan. There's no best practice alert or anything like that you get with sepsis or those kind of things, which is why it's going to be really important to make sure that you have those job aids and infograms that are available to you on the website. You're going to need those. Remember that in real life on the unit, because we don't always keep track of our papers, we go to the mental health page, and all those documents that you have available to you came from the mental health page. They recommend that you ask the Columbia Suicide Severity Rating Scale questions directly as written. If you remember like the NIH neuro exam or the CWAS scale, any scale like that, the questions are meant to be asked directly as written so that whatever answers you get, whatever score, is then comparable from one assessor to the next, right? It makes it more valid data. So we ask the questions as they are written. And then you're going to do your best to determine a risk category. So there's 6 questions on the Columbia, right? And so sometimes when you take something off of a piece of paper and you stick it into Epic, it gets a little bit confusing. So you'll see in this screenshot, the first 3 questions that you are going to be asking your person are actually questions 1, 2, and 6. And the reason they do that is because these are the low risk questions. Depending on how you answer these, you may see the high risk questions, right? See how you have that little special mark on the side that lets you know that with question 2 and question 6, there's more stuff behind it depending on how you answer it, right? So questions 1 and 2 count as low risk questions. We try not to remember things, right? This isn't something that you should plan to recall. That's what that infogram was for, right? It tells you the questions 1 and 2 are low risk questions. In the past month, have you wished you were dead or wished you could go to sleep and not wake up? In the past month, have you actually had any thoughts of killing yourself? So if I say yes to just those 2 questions, that puts me in the low risk category. However, if I say yes to question 2, that is going to open up questions 3, 4, and 5, which means that I may fall into a moderate or high risk category based on those. But let's just stay with the low risk questions. So they said yes to 1 and or question 2. What does that mean for you? Well, there's a couple of flow sheets that you're going to have to add to Epic. One of them is called Daily Behavioral Obs and Cares. And that's kind of a weird name, but what that is your daily shift assessment for the Columbia Suicide Severity Rating scale. So that is just a rephrase of those same questions. Mental health tells us that people tend to kind of wax and wane as far as whether they're feeling all right or whether they're having an issue. So we are reassessed just like we would anything else to track, to be aware of where they are at. We would also add depression and anxiety care plans. Remember when we talk about care plans in Epic, it's not the same thing as in nursing school. I'm sure you all remember the painful care plans from nursing school that really didn't serve a practical purpose. In Epic, when you add a care plan, it tells you what interventions your person needs, right? Evidence-based, updated pretty often, so they're actually a tool for you to use to make sure you're actually providing the best care for your patient. Do you know what you should be doing for somebody with depression and or anxiety? Maybe, right? But this will help you be more sure. So do please use those and see what they say. Consult spiritual care is appropriate. Remember that is a nurse-to-nurse consult, so you can have them come by. And then we also always have to do the patient education. We should never be calling up somebody like spiritual care without having a conversation with a patient, right? You can't be like, oh, this is uncomfortable, I'm going to make spiritual care do it and call them up on the sly, right? No. You are the person who is allowing or modeling behavior to allow this to be a conversation that we can all have, right? So you are upfront and you are open about the questions that you have asked and how they have scored and what you can do to help them. So we will then have an avenue open to us like, oh, and here are the handouts that are related to anxiety and depression, and here's one about the warning signs of suicidal thoughts, right? So they're all CRAMES handouts that we would then give to our person. We would document those on our patient education. And then on discharge, again, part of a safe discharge is making sure they have the crisis line number And then ideally follow-up appointments through discharge planning for mental health. Now, and this is just how you add in some of those flow sheets. Now, wrenching in flow sheets is usually pretty straightforward. The daily behavioral obs and cares, you should take just a moment to look at the screen. Do you notice that normally when you add a flow sheet, there's 3 boxes on the slide that you can look in, right? There is documented on, there is preference list, and there's facility preference list. The default, the one that pops up when you don't do anything, is the middle one. It's preference list. It's almost everything you need is there. Daily behavioral obs and cares is not there. You have to click over to where it says facility preference list. That's where you find that. It's a bigger box. So sometimes when something isn't in preference list, it's in the bigger box to the right. But you just have to remember to look over there because I don't do it very often. And then we'll find it. We'll be able to add it and to document appropriately. Talked about adding the care plans, talked about adding or providing cranes, right? Because, again, we're modeling the behavior that it is okay to talk about this. We're not going to get squirmy and weird. Now, what if, when we asked question 2, our person says yes, and that, again, opens up questions 3, 4, and 5. And then we'll also talk about 6 here in a second. So question 3 puts you in the moderate risk box. Question 3 is, have you been thinking about how you might kill yourself? If your person says yes to question 3, then that will land them in moderate risk, as well as question 6. Question 6 was, have you ever done anything, started to do anything, or prepared to do anything to end your life? Now, if your person says yes, the next question that pops up is time frame. Okay, was that in the last 3 months, between 3 months and a year ago, or over a year ago? If they say those second 2 choices, 3 months to a year, over a year ago, that is the second way that somebody ends up in the moderate risk box. So remember, low risk was questions 1 and 2, moderate risk is questions 3, and possibly question 6 if it was between 3 months and a year ago and over a year ago. So that now we are looking at, well, our person is now moderate risk. So all those things that we're going to do for low risk, we are also going to do those and a couple of other things. We might remove items that are not needed for care. You don't need your sharps box in the room if you can remove it. You might consider changing out your plastic trash bags for the paper ones that housekeeping has. Are there any obvious, cords, ropes, things like that that can be removed? Monitor visitors. Do you need to search their belongings? Do you need to order paper service? Should we add a suicide risk care plan? So you'll notice that there's a lot of consider and maybe and what do you think in the moderate risk category. You and your provider, you and mental health, you and your charge nurse are going to decide. You're going to assess and determine which one of these are needed or useful. Not everything is helpful to every patient, right? So we make some decisions on what we should do. You'll notice in bold at the bottom it says consider using telesitter. The only time we cannot use telesitter is when we score in somebody into high risk. Then they must have a sitter and it must be an actual person, right? But we're not there yet. This is moderate risk, and if you're feeling kind of nervous about them, then a telesitter would be an option for them. Talked about the things that we might consider removing from the room. Now, if you look at this list of things, you'll notice that this list is the same as that paper handout that we had available to you from Yammer, right? Because we don't remember stuff, we just find the reference so we have it when we need it. All of your references come to you from the mental health page. So we would go, we would print it, and we would take it in. Because when you read this list, it probably seems pretty obvious, like of course you would remove those things. But then if I cover up that list, will you still be able to tell me everything that was on it? Well, of course not, right? So that's why you take the list with you when you're setting up a room to admit someone in the moderate or high risk category. Once again, we are adding care plans. We might consider having a safety plan template. And this, again, expect support from mental health for these kind of things to help make sure that we are planning to keep our person safe and as they step toward the safe and comprehensive discharge. We would plan to ask our provider to put in a psych consult. Now, a psych consult is a provider consult, it's not a nurse consult. So your provider will need to do that so that they can come by. So for moderate and high risk, we would be looking for psych consult to help us out, to make sure that we are keeping our person safe. So we had low risk, we had moderate risk, and the next question that shows up, of course, is going to be high risk. How does your person end up being high risk? Well, they said yes to question 4 or 5. Question 4 is, have you had these thoughts and had some intention of acting on them? Have you started to work out, or have you worked out the details of how to kill yourself? Do you intend to carry out this plan? Right? So that's questions 4 and 5. And then the other question would be 6. Remember how we said question 6 could be moderate? Well, it can also be high risk. If the answer was, have you ever done anything, started to do anything, or prepared to do anything to end your life? And if you said yes, then how long ago? If it was within the last 3 months, that first choice, that is the other way to end up high risk. There's 3 ways to end up high risk. Question 4, question 5, or question 6 if it was within the last 3 months. Now, interventions for high risk, we would do everything we said we were going to do for low risk and moderate risk, and there's a couple of other things. What you do about a high risk patient, like all those things with moderate, we're like, well, you could consider, and maybe, and what about this? It's much, much more prescribed. It's those things are necessary. We will do them. We will clear their room. We will make sure they're on paper service. And the key to a high risk is that they now need a one-to-one person, an actual person to monitor them all the time. They don't get to go to the bathroom by themselves. So we are very, very much in their space with the goal of safety. Remember that safety is in the end your chief duty. So it does trump things like privacy. So safety first, and so that person is always within sight, and you always know where their hands are. You'll notice that on here there's also a reference to the in-person continual visual observation handoff tool. We'll talk about that in a second, because there's a couple of other things that we add in when somebody lands high risk. Remember, highly regulated, so we need to make sure that we're following our processes. So in addition to those reassessment flow sheet. So an assessment is done by a nurse, right? So your nurse did those. There's going to be 2 additional flow sheets that we're going to add that are actually observations, which means they can be completed by your sitter, because a lot of times our sitters are CNAs, right? Observations can be done by sitters. The other thing that they ask, because of, highly regulated, is that you put in a nurse-to-nurse communication order that says that you have your person with a one-to-one sitter. Now you'll notice that this next slide shows up and they're talking to us about spice-colored scrubs. Remember that the spice-colored scrubs are reserved for patients who are restricted from discharge. We don't use them for anyone else because it's important for security to know that if they see someone in that outfit, they need to stop them, sometimes physically, from leaving the premises. So remember that not everybody at risk for suicide is also restricted from discharge. So you need both of those things to be true. You also notice on the slide, there's the bolded underlined statement that says, suicide risk patients of any level are not forced into spice-colored scrubs. So you can suggest and cajole and all of that, but we do not force if the reason you're putting them in is for suicide, right? And then we already talked about the reevaluation of suicide that we're going to do with the daily shift screen, that daily care, behavioral care and OMS. Now, what if your person screens into a category level that you do not think is appropriate, right? Because we're relying on what somebody verbally states us, and sometimes we get a feeling that that may not be true. Mental health is a lot more subjective than we may be comfortable with in regular adult acute care. So there's a plan for that, right? So if you're like, this person's saying they're doing fine, that is not my impression, I think in fact they are much higher risk than they're saying, well, then we call up our provider or we talk to our charge nurse and we make that decision. Or what if we're like, my person is saying that, all these things that would make them really concerning, but don't that does not seem to be supported by anything that they're doing or any of their history, right? So once again, we go back to our provider. To change somebody's risk level, we have to document, right? It's a narrative note, rationale, who do we consult to make that decision? And then again, definitely consult mental health so they can come by and help you with those decisions when they're available. For instance, we had a story coming out of I forget where a patient answered yes to all 6 questions. Every question they said yes to. So they got a sitter. Now, the other half of that story, though, is that particular person, they said yes to every question that they were asked, right? Didn't matter what the question was. So you can see how that would not really be a valid way of assessing their suicide risk. So did they need a sitter? Probably not. So that is a decision that you can make on your unit in a huddle. Another story that came out was, again, another patient who said yes to every question. They were oriented, but that person did not actually have the physical ability to harm themselves. They were not mobile enough to do so. So, yes, we need to make sure that we are involving mental health and putting them, on a path to get treatment. But does a sitter make them more safe? Well, no, right? So those are questions that, not everything can be answered just by the Columbia, right? There's, sometimes it's more complex. So make sure you're having those conversations about your sitter use. As we said, we reassess as needed. Remember, suicide risk is we're trying to model the behavior that thoughts and feelings are valid. We are non-judgmental, but we do want to help and keep someone safe. So these are, we model that so that your person feels like you're not silently judging them based on what they are expressing to you. And that's a lot of verbal communication. We talked about the documentation. One thing I would like to point out on this particular slide is that Epic doesn't clearly tell you which choice you should pick here on the drop down, but there is something you should consider. So if you have an actual live person that is a sitter, then you choose the selection that says at bedside. If you have the remote monitoring for somebody who is at a lower moderate risk, or for any other reason you're using the remote monitoring, that would be the telesitter, right? And I understand that when you have the telesitter is at bedside. I understand, but that is not how this drop-down menu is used. So at bedside means an actual person. Telesitter means remote. When you're filling out this particular website, again, suicide is highly regulated, so please make sure that you are documenting appropriately. We talked about the observation. So a person is high risk. You are doing your reassessment with your shift assessment. But there's also 2 observation flow sheets that you're going to add. Like this one is the suicide psych obs. Observations are filled out by your sitter, and they're filled out every hour. Just go down the drop-down menus. This next screenshot is of the mental health page. Remember how we were talking about where your resources came from? Because this is not stuff you keep in your head. This is where they came from. All those things that we have given you are from here. The highlighted one on here is the environmental risk assessment for suicide patients. Because remember how our chief duty was to keep a person safe from how to hang themselves, right? So we were going to mitigate the ligature risk. But we aren't actually good at knowing what a ligature risk is. Well, mental health and compliance, they all went through every patient room in the house or building, and they pulled out what were risks, and that's where this Excel comes from. Now I realize that this is a little unfriendly when you're looking at it, but just bear with me for just a second, right? So suppose you're admitting somebody to 7A, right? Or you would scroll down to the D tower if you're admitting somebody into the D tower. So admitted somebody in 7A, and you're going across the row, right, patient room 7A, and you get to something that's red. Remember in Epic, when a number turns red, it's because it's bad, right? So you go here and you see that H turned red. So we go up here and we see that H says improper clothes hangers, hooks, or towel bars. Those are permanent fixtures in your patient's room. You can't remove those. So what is your plan to mitigate? Well, that's why we have a live sitter that is physically present in the room to keep your person safe from those. But as a nurse, you're aware of the risk. So you just keep going across the line to all of the numbers that turn red, and you go up to the key at the top to explain what that risk is. That is how you avoid trying to keep all that stuff in your head, right? We go to the reference that helps us. The safety attendant handoff tool is for the sitter. You know how in acute care, a lot of times when we need to do an in-person sitter, we don't have an extra staff member that shows up. We just start a sitter rotation with the people that we have. So we change out that sitter every 30 minutes. Well, that's pretty quick, right? It's going to be hard for people to keep track of, well, why does this person need a sitter and what are we doing to keep them safe. So that's where this tool comes in. And then at the top, the nurse fills it out, like why do we have a sitter? Where is that patient allowed to be? And what things in the room could we not take out? Do you have one of those sharp spots that is pretty well stuck to the wall so you couldn't remove it? Well, it's still going to be in there so that at a glance, every 30 minutes, your new sitter can have all the information that they need to help keep your patient safe. And as we said, we added in that communication order. The last thing that you'll want to do is you're going to want to look at these last couple of slides that give you an opportunity to use your handouts and practice, right? So you'll see that this person got a PHQ-4, so the anxiety depression. Their total score was 9. So that opened up the Columbia, and you see on the Columbia scale they answered all 6 questions. Yes, question 6 was within the last 3 months. So which risk category would your person go in? Are they low, moderate, or high? Well, we would put them in the high risk category, right? Remember questions 4 and 5, and also question 6 within the last 3 months is what lands you in the high risk category. Here's another patient who also had a high enough PHQ-4 for the Columbia to open. We see they said yes to questions 1, 2, and 6. Question 6 was between 3 months and a year ago. So where does that go? Well, again, I'm going to look at my handout that tells me, and I'm going to say, oh, well, questions 3, but then also question 6, if it was 3 months to a year ago or longer, puts me in the moderate risk category. Here's another person. This person only saw questions 1, 2, and 6. They said yes to question 1. They said yes to question 6 within the last 3 months. So remember, oh yes, question 6, if it was within the last 3 months, lands you in the high risk category. I think this is our last example. They said yes to questions 1, 2, and 3. They also said yes to question 6, but it was over a year ago. So remember that when we say yes to question 3, that lands us again in the moderate risk category. And that is the end of our slideshow for suicide prevention. Again, pay attention to the mental health webpage. Gail Springer, our clinical nurse specialist for mental health, has her contact information there if you have any further questions. And you can also post them on Yammer, and we'll be happy to respond. Thank you again.